Buenas tardes para los que ya están conectados a este webinar. Les pedimos un poquito de paciencia. Vamos a dar 1 o 2 minutitos más para que se termine de conectar la gente para luego dar inicio a la sesión. Bueno, buenas tardes a todos. Soy Angélica Figueroa, la encargada de educación de la empresa Medtronic, y hoy día estamos apoyando el desarrollo de este webinar que va a hablar acerca del procedimiento de ROS con la visión latinoamericana a cargo del doctor Juan Contreras, que va a ser el director, es el director del curso, el doctor Juan Contreras, cirujano cardiovascular del Hospital Hernán Enrique Aravena, además miembro de la Universidad de la Frontera de Chile, y hoy día cursando el Advanced Cardiac Fellowship en la Universidad de Toronto, en Canadá. En esta actividad, el doctor Contreras va a estar a cargo de presentar a los destacados expositores y además al moderador de este webinar. A continuación, le voy a leer el descargo de responsabilidad y después le voy a dar un par de datos. Esta presentación se ofrece con propósitos educativos con el fin de explicar de manera general el funcionamiento de alguno de los dispositivos médicos marca Medtronic. Sin embargo, este material educativo en ningún momento se constituye como una certificación o licencia profesional que lo capacite para tomar decisiones médicas respecto al uso de los dispositivos médicos mencionados en la presentación, toda vez que esta decisión del uso es exclusiva del médico tratante. Asimismo, esta presentación no reemplaza la necesidad de consultar el manual de instrucciones de cada dispositivo médico. Cualquier opinión expresada en este programa son opiniones propias del entrenador y no representan las opiniones o puntos de vista de Medtronic. El presentador es responsable por todo el contenido y cualquier permiso necesario. Preguntas sobre el uso de productos pueden ser direccionadas al Departamento de Medical Affairs usando el link que está abajo, o puede entrar en contacto con un representante de Medtronic. Para nosotros, para nuestra compañía, nuestra principal misión es contribuir al bienestar humano mediante la aplicación de la ingeniería biomédica en la investigación, diseño, producción y venta de instrumentos o equipos que nos permitan aliviar el dolor, restaurar la salud y prolongar la vida de nuestros pacientes. Antes de dejar con ustedes al doctor Contreras, les quiero comentar que esta presentación va a ser solo en inglés, no hay traducción al español. Y lo otro, después que termine de realizar las presentaciones, se va a pasar una encuesta muy pequeña de 3 preguntas que es para los asistentes y la cual no sería de mucha utilidad que ustedes las pudieran responder. Y lo último es todas las preguntas, comentarios que quieran hacer, por favor déjenlos en el chat. Este chat va a estar siendo monitoreado por los participantes, por los asistentes y por los moderadores. Así es que cualquier comentario, duda, podemos en el fondo ir respondiéndola hacia el final de la presentación. Si necesitan que les habilitemos el micrófono para poder hablar, ¿no? Porque hoy día, en este momento, lo tienen deshabilitado, por favor nos colocan un mensaje y nosotros lo ubicamos y podemos habilitar el micrófono. Sin más, mediar nada, antes de iniciar la sesión, doctor Juan Contreras, bienvenido, muchas gracias, y todo suyo el webinar. Doctor, está en mute. Doctor Contreras, tiene que habilitar eso, el micrófono. Ahí.
Perfecto. Como comentaba anteriormente, esta sesión va a ser principalmente en inglés, pero si tienen cualquier pregunta, háganla en el chat. Tenemos a 2 moderadores, los cuales nos van a servir de guía en esta introducción. Well, good morning to everyone. My name is Juan Contreras. I'm a Chilean cardiac surgeon, currently at Toronto General Hospital. I used to work in Hospital Hernán Enríquez Aravena and in Universidad de la Frontera in Chile as coordinator and on behalf of the Chilean Society of Cardiology or Cardiovascular Surgery. I want to say hello and thank you first to our speaker, our attendant. We are so happy. We have more than 200 attendants at this moment, not only from South America. We have attendants from Europe, Asia, and Africa. As well, I would like to say thank you to LACES, the Latin American Society, to share by social media this meeting. And finally, I would like to say thank you to Nectronic, especially to Angelica, Patricia, and Renato for all your support in this activity. The Chilean society, as you see, Chile is the last country. We have different branches, but we cover mainly the south part of Chile. We are almost 70 members, and we have around 3 million of inhabitants. We cover different beautiful cities in the south of Chile, like Pucón, Punta Arenas, Valdivia, Castro, Ancud, Osorno, and Puerto Montt. And I would like to present the speaker. Our first speaker is Dr. Amin Massin. He's a resident of PG4 in University of Toronto. He's an active researcher. He has more than 72 scientific articles. And the main topic for him is obviously ROS procedure. And currently he's working in his PhD in study for different stem cells in cardiac surgery. And he is going to talk about current evidence and indication for the ROS procedure. Our next speaker is Dr. Eduardo Turner. He was trained by Dr. Barnard in South Africa. He is the pioneer in aortic disease and valve disease in Chile. Currently, he working as a cardiovascular surgeon in Clínica Santa Maria, Instituto Nacional del Tórax, maybe part of the most important hospital in our country. And he's going to talk about Chilean experience of ROS procedure. Then we have Dr. Ismael Helmahansi. He's a director for the aortic surgery in Mount Sinai, New York. He trained initially in Montreal, and then he did a fellowship mentored by Dr. Osir Majid Yaqub. He has more than 150 articles, and he's an active research and surgeon in this topic. He's going to talk about how to do and teach the ROS procedure. And finally, we have Dr. Francisco da Costa. He worked in Instituto de Neurología y Cardiología en Curitiba. As well, he's an active researcher and surgeon. He has performed more than 500 procedures in Brazil, and he's going to talk how to build a ROS program in South America. And finally, we have our panel of discussion. We have Dr. Juan Carlos Famondes. He's the chief of the Hospital Hernán Enríquez Aravena in Chile. Dr. Alex Stocking, he's the chief of the Gran Benavente in Chile. And if we have the opportunity, maybe at the end, Dr. Roberto Favaloro, he's going to help us in the panel discussion. Thank you to everyone again, and please, happy to listen to your presentation.
Can you see my screen?
Yeah, we can see it.
Great. Gracias, Juan. Y, muchas gracias por la invitación. Buenas tardes a todos. Es un gran placer estar con ustedes para discutir el procedimiento de ROS en adultos. And that is all the Spanish that I will be able to provide today. The rest will be in English. So I was tasked with discussing the current evidence and indications for the Ross procedure in adults. And I have no relevant financial disclosures in regard to this talk. When we talk about the Ross procedure in adults, we usually refer to young and middle-aged adults. And it's important from the get-go to recognize that these patients are different from their more elderly counterparts. They truly represent a unique patient population. Specifically, these patients tend to have higher levels of physical activity. Many of them have busy professional lives. They put a lot of emphasis on quality of life. And perhaps most importantly, because they have a longer life expectancy, they have a greater cumulative exposure to potential valve-related complication over the course of their lifetime. Now, before talking about the Ross procedure in these patients, we must first discuss the alternative, which is the most commonly performed operation, which is standard AVR. And historically, these patients have been treated with mechanical aortic valve replacement. Several years ago in Montreal, we examined the outcomes of young patients undergoing mechanical AVR in this study that was published in JTCVS. We looked at 469 isolated mechanical AVRs in patients under the age of 65 operated between 1997 and 2006. The mean age of the population was 53 years old, and this was a highly selected patient population. We excluded any patient who had had previous cardiac surgery, anyone undergoing concomitant procedure, and we only included elective cases. The mean follow-up was 9 years, and it was 95% complete, yielding a total of 4,000 patient years of follow-up. And the results were quite sobering. When we compared the survival of these patients, these young, otherwise healthy patients, to that of the general population, we saw an excess mortality apparent already after only a few years of follow-up. At 10 years, the survival was only 87% compared to 94% in the general population. Furthermore, when we look at survival free from reoperation, we see that at 10 years, only 82% of patients are alive and free from reoperation. In other words, in this highly selected cohort of young and middle-aged adults, at 10 years, 1 in 5 patients is dead or reoperated. Around the same time, we also examined the outcomes of bioprosthetic AVR in young and middle-aged adults. As you know, this is increasingly being offered to young patients in the era of TAVI and the promise of valve-in-valve TAVI. And so this cohort, a very similar cohort, patients operated between 1991 and 2011, 144 isolated bioprosthetic AVRs, patients under the age of 60. The mean age was 51. Again, we excluded anything that could complicate the operation. And again, we had a follow-up of 10 years, 95% complete. Once again, the results were not great. In green, you have the expected survival of these patients, and in blue, you see their actual survival with quite significant excess mortality, under 50% survival at 15 years. So these are single center studies. What about population-based data? I'm sure you are all familiar with this paper, which was published in the New England Journal of Medicine a few years ago. This was a California-wide study looking at outcomes of all patients undergoing biological or mechanical valve replacement in the state of California. And these are the results for patients undergoing AVR. These are patients between the age of 45 and 54, and we'll focus on those because they're the most relevant ones. And a lot has been made about this result, which suggests a slight but statistically significant advantage of mechanical valves over bioprosthetic valves in this age group for patients undergoing AVR. However, I think that focusing on that is really mistaking the tree for the forest. I don't think that's the most important message of this graph. I think the most important message of this graph is if you look at the actual numbers, by 15 years, 25% of patients who undergo mechanical AVR are dead, 30% of those who undergo bioprosthetic AVR are dead. These patients have an average age of 50, so 15 years of follow-up brings them to 65, the end of their professional life, the beginning of retirement perhaps. A quarter, at the very best, a quarter of these patients will not see retirement after prosthetic AVR. A very similar study conducted in Sweden in the Swedish Heart Registry again, demonstrating excess mortality. In red, you have the expected survival per age group, and in blue, you have the actual survival of patients undergoing either bioprosthetic or mechanical AVR. And as you can see, there is excess mortality associated with the use of conventional AVR. And what is more, the excess mortality is more pronounced the younger the patients are. So the conclusion from these studies is that prosthetic AVR in young patients is palliative. It is not a curative solution. And the reasons for this are very well sort of known. We know that both of these prosthesis types have significant shortcomings. In the case of mechanical valves, thrombogenicity, the requirement for lifelong anticoagulation, and in the case of bioprosthetic valves, the limited durability and the high need for reoperation. And this is how we typically think about these two options and the trade-off. But I would invite you to think about these options in a slightly different manner. Rather than focusing on what's different between them, I would urge you to think about what they have in common, which is that they both represent acellular, non-living substitutes with no potential for growth, repair, or adaptation. In contrast, the structure that they seek to replace, the native aortic valve, is very much a living structure. We know that aortic valve leaflets are cellularized. They contain various populations of cells that are responsible for secreting a highly sophisticated and organized extracellular matrix that confers the valve its unique properties. And these properties can really be summed up in two main properties, which is the ability for crosstalk and the ability for dynamism. In other words, every component of the aortic root throughout the cardiac cycle has the ability to adapt and respond to its hemodynamic environment. And this allows the valve to change its shape, conformation, and stiffness throughout the cardiac cycle to promote optimal flow and minimize stress on the valve leaflets. If you think about it, an aortic valve leaflet is about 0.5 millimeter thick. It's a very, very thin, delicate structure, and yet it opens and closes over 3 billion times in the course of an average human lifespan, in most cases without any significant wear and tear, which can only be achieved if you have a living structure in place. And so to summarize the living nature of the aortic valve is a living structure that exercises complex functions, which promotes durability, excellent hemodynamics, low thrombogenicity, and resistance to infections. And the rationale behind the Ross procedure is that the complex functions of heart valves, and in this case of the aortic valve, can only be recapitulated with a living substitute. And that's where the Ross procedure comes into play. The Ross procedure is currently the only replacement operation that allows for long-term viability of the aortic valve and the aortic root. So the hypothesis is that these properties and its living nature will allow the autograft to lead to optimal long-term outcomes. So I'm going to share with you some of the evidence surrounding that, starting with our local experience here in Toronto, led by Dr. Tyrone David, who reported a few years ago the 20-year outcome of the Ross procedure. This was a cohort of 212 patients operated between 1990 and 2004 with a mean age of 34 years and a median follow-up of 14 years. And as you can see, survival is excellent. Here you have in blue the survival of the general population, and here you have in black the survival of the Ross cohort, and they're hard to delineate because they're so close to each other. In fact, there was no significant difference at 20 years in survival between the Ross patients and the age and sex matched general population. Furthermore, freedom from reintervention was also excellent. You can see that in the second decade, this starts to increase, but I should point out that these reoperations include all reoperations on either the aortic or pulmonic position, and they also include percutaneous reinterventions. We're talking about current evidence, and so this is sort of the most current evidence available. This is a paper that was published 2 days ago in JACC from the German Ross registry, looking at the long-term outcomes of 2,444 adult patients who underwent the Ross procedure across 10 European centers in the German Ross registry. The mean age was 44 years old. Importantly, the operative mortality in this entire cohort was only 1%. And these are patients that date back, mind you, to 1988. And so it shows that as long as the operation is performed in a center of expertise by dedicated surgeons, a very, very acceptable operative mortality is achievable, one that is not significantly different from that of prosthetic AVR. In any event, the median follow-up in this cohort was 9 years, and the follow-up was 88% complete, yielding a total of 23,000 patient years of follow-up. These are the outcomes. In blue, you have the expected survival of the age and sex matched general population, and you can see that by 25 years of age, the Ross procedure still has a survival that is equivalent to the general population. In addition, you have here the breakdown of the various complications, an extremely low linearized risk of complications such as bleeding, stroke, thrombosis, or endocarditis, and a very, very respectable rate of reintervention on either the autograft or the RVOT. So these are just two examples of studies, but there have been many more. This is a review that looked in 2018 at all the published contemporary series looking at long-term outcomes of the Ross procedure in adults. You'll recognize some of the names of our distinguished panelists on this. And basically, the results are quite consistent. I want to draw your attention to 15-year survival here, which ranged in these large studies between 87 and 95% at 15 years. Most of these studies reported a survival that was equivalent to the general population. And again, if you keep in mind the figure I showed you earlier about the results at 15 years of bioprosthetic and mechanical AVR, the contrast is quite stark. In addition to these case series, there is an increasing body of evidence comparing the Ross procedure to other surgical alternatives. And this was really started in 2010. This paper by Dr. El-Hamamsi was a bit of an avant-garde paper. It is the only randomized controlled trial in this space, and it looked at long-term outcome of the autograft versus homograft aortic root replacement at the time. Of course, the homograft has fallen out of favor since, but nonetheless, this was a randomized controlled trial and an important study. And I won't spend too much time discussing the details, only to highlight that this was a relatively complex patient population. 8% of patients had active endocarditis at the time of surgery, and nearly half of the patients in either group had undergone previous surgery. And despite that, when you look at the outcomes in terms of survival of the Ross procedure were non-different from that of the general population. And of course, there was a significant advantage of the Ross over aortic homograft replacement. More recently, our group in Toronto published the long-term outcomes of the Ross procedure versus mechanical AVR. This was a propensity match study in which we compared the two treatment options, and we found a statistically significant advantage of the Ross procedure over mechanical AVR in terms of freedom from cardiac and valve-related death. Surprisingly, there was no significant difference in terms of reoperation between mechanical AVR and the Ross procedure. And of course, this is one of the touted advantages of mechanical AVR, which is a relatively low risk of reintervention. But you can see that with the Ross, we achieve similarly low rates of reintervention at follow-up. A very similar study out of Peter Skillington's group in Melbourne, published in JACC in 2018. Again, a propensity matched comparison between the Ross procedure and mechanical AVR. And at 20 years, there was a significant advantage of the Ross procedure in terms of overall survival, all-cause mortality between these two comparable patient populations. So for the last few minutes of my talk, having highlighted these excellent long-term outcomes, I'm going to talk a little bit about patient selection and indications. And for this, I'm going to rely heavily on this state-of-the-art review paper, which was published in JACC a few years ago. You'll recognize some of the names on this review. These are really thought leaders and pioneers, and the review included a patient treatment algorithm, which I want to go through with you. First, highlighting the advantages of the Ross procedure, which I just discussed with you with the studies I presented: excellent long-term survival, excellent quality of life, avoidance of anticoagulation, superior hemodynamics, and low rates of valve-related complications. Also acknowledging the potential pitfalls of the operation, which is that it's a technically complex operation. It has the potential long-term failure of two valves, and the reoperations can be complex. All of this to highlight the fact that this is not an operation that should be performed casually or sporadically. It needs to be kept in the hands of dedicated aortic reconstructive surgeons operating in centers of excellence. All that being considered, this is the patient treatment algorithm that I was referring to a few moments ago. And I think it's worthwhile to go through it systematically. So we'll start here at the top with patient-related factors. So who are the ideal patients, adult patients for the Ross procedure? These are patients with high levels of physical activity, and in particular in women contemplating pregnancy, the Ross procedure is an appealing option. Young and middle-aged adults with unrepairable aortic valve disease. So this is important, in particular for patients with aortic insufficiency, aortic valve repair, and aortic valve sparing root replacement are the treatments of choice, and the Ross procedure should not be favored over those. And patients who don't have any contraindications to the Ross procedure, so no familial aortopathy, connective tissue disorders, autoimmune disorders, and patients with a limited life expectancy, less than 15 years of age, these patients do not stand to derive a benefit from the Ross procedure, and it should be avoided in these patients. Otherwise, in a patient less than 60 years of age with isolated aortic valve disease, you should really look for a reason not to do the Ross procedure instead of looking for a reason to perform the Ross procedure. Now, having considered these patient characteristics, we now look at anatomic characteristics. And the way we think about it really is you have two types of patients. You have the patients with an ideal anatomic substrate, and we'll talk about these first. These are patients with aortic stenosis and a small or normal-sized aortic annulus. These are the ideal candidates for the Ross procedure, and really you can perform any technique, subcoronary implantation, inclusion technique, full root replacement. The results are excellent. If you look at these patients here that have no size mismatch between the aortic and pulmonary roots, that have an aortic diameter of less than 27 millimeter, and who present with aortic stenosis, the 15-year freedom from reintervention on the autograft is truly, truly remarkable, 97% and more. And it is these results that have led our group in Toronto to consider now the Ross procedure as the best operation to treat aortic stenosis in young and middle-aged adults. Now, how about patients with a suboptimal anatomic substrate? So these are patients who have aortic insufficiency or mixed lesion with predominant aortic insufficiency. They often present with a dilated aortic annulus, often in the context of bicuspid aortic valve. And sometimes they present with a size mismatch between the aortic and pulmonary roots. So what about these patients? Should we discard the Ross procedure in these patients? I would put to you that we should not discard the Ross procedure because the advantages that I mentioned earlier of the Ross procedure, including excellent long-term survival and low rates of complications, these advantages still exist for these patients. If you recall this table that I showed you a few slides earlier, looking at long-term outcomes of the Ross across various series, it is worth noting that a significant proportion of patients in these series, in fact, the majority, had either bicuspid aortic valve or aortic insufficiency or some combination of both. And yet, despite the fact that these series included predominantly patients with this profile, the long-term results are excellent, both in terms of survival and in terms of freedom from reintervention. And so rather than throwing the baby with the proverbial bathwater, what we believe is the best approach is to tailor the Ross procedure to patients with aortic insufficiency and this less than ideal subanatomic substrate. This can be done in many ways. I won't go too much into the technical details as we have another talk on the technique, but suffice it to say that this can be achieved via several techniques. Our preference is either the autologous inclusion technique or this tailored surgical approach. These two approaches have the advantage of preserving the mobility of the autograft, and so we are a little bit weary of encasing the autograft in a Dacron jacket because we feel that it mitigates some of the proposed advantages of the procedure, namely the dynamism and free mobility of the aortic root. And the best illustration of what can be achieved with a tailored Ross procedure in patients with bicuspid aortic valve and AI comes from, again, Peter Skillington's group in Melbourne. They looked at the 20-year outcomes of 129 consecutive patients with BAV and pure aortic regurgitation. The mean age was 35 years old, and the mean follow-up was 10 years, and they used an autologous inclusion technique in all patients, and the results are quite remarkable. excellent long-term survival and a very, very respectable rate of reintervention or recurrence of more than mild AR. So they included even patients who did not undergo reintervention but had moderate AR follow-up. And despite this pretty stringent outcome definition, the freedom from a redo or mild AR was 85% at 20 years, compares very favorably to other options. One last point to mention, and a last point of emphasis, regardless of the anatomic substrate of the patient, it is extremely important to ensure tight postoperative blood pressure control in the early postoperative period, ranging from the first 6 months to really the first year. This is important to allow the pulmonary autograft to adapt to its new position within the aortic root. And it is important in all patients. It is particularly critical in patients with AI and a dilated aortic annulus. So in conclusion, some take-home messages. The Ross procedure is the only replacement operation that allows for continued viability of the aortic root, and that confers to the Ross some unique properties. And because of these properties, the Ross procedure is the only operation that restores normal life expectancy to non-elderly adults undergoing AVR. Aortic stenosis and a normal-sized annulus represent the ideal anatomic substrate for the Ross procedure. However, a modified Ross procedure is an excellent option in young and middle-aged adults presenting with non-repairable AI. And finally, the Ross procedure should be performed by dedicated aortic reconstructive surgeons in centers of excellence. Thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Amin, for your presentation. In order to continue the time, we're going to do the question at the end of the presentation. Okay, thank you very much, Amin. Our next speaker is Dr. Eduardo Turner. He's going to talk about the Chile's experience of Ross procedure. Dr. Eduardo Turner, please.
Thank you, Juan. It seems that I've lost my, oh, it's here. Can you see what I'm showing? Am I sharing my talk?
No, you're not.
Oh, no. I'm terribly sorry, but something seems to be terribly wrong here. Just a second, please.
Well, maybe we can advance with the next speaker, and you can
Yeah.
tell me, Dr. your slide, Dr. Almahansi.
Thank you. So let me try to share my screen. Do you see it now?
Yes. Yes.
Okay, great.
We can see it.
And please don't hesitate to interrupt me if you see that the videos are a bit patchy, and we'll see what we can do. So thank you very much for the invitation, Juan, and it's a real honor for me to be a part of the Chilean Society tonight. And I will just try over the next 15 minutes to detail a little bit the steps of the Ross procedure, at least how I do it. And 15 minutes is certainly not enough. This is a paper that was published a couple of years ago by Amin, who just spoke and gave this brilliant presentation before me that really goes into the very gritty details of how to do this operation. I'm showing this slide because for all the young surgeons who are on the panel, and I saw a question asking how can we learn and how can we start, and Dr. Da Costa will tell us a little bit about how to do that as well. But just to show you that I joined the Montreal Heart Institute in 2010, and you can see that there was very little aortic surgery or aortic root reconstructive surgery being done then. So the notion that you can only do these operations in centers where they are already being performed at a high volume is maybe exaggerated. I think you need to have a real interest and commitment to aortic anatomy, physiology, and surgery to be able to start a program, and then you can really build in a safe way on that. But going back to the technique, so I'll walk you step by step on how I do it, and please interrupt me if you see that the videos are patchy. I'd like to dissect the pericardium off the face of the aortic arch, and then to cannulate the aorta over a wire, as you can see here, under echocardiographic guidance. And what that does is it allows us to clamp the aorta just proximal to the innominate artery, and by doing so, it really takes the clamp away from the distal PA, and this way it makes the distal pulmonary homograft anastomosis much easier. Let me just try to get the volume off. Okay, and then this is valve examination. In this case, it's a unicuspid valve. You can see the left non-commissure, and it's important to take the time to examine the native valve, and more importantly, the symmetry between the commissure and the raphes, because it's not always symmetrical. And if it's not symmetrical, such as in this case, it's important when implanting the autograft to not necessarily follow the angle of the commissures and raphe on the aortic side, but rather to take a freestyle sizer or something to place 3 commissures at 120 degrees. And then the next step is mobilizing the coronary arteries. I like to mobilize them in a rectangular shape. This really maintains their orientation, so there's no torsion when you reimplant them. And also to keep about 2 millimeters around the coronaries. And I always put a suture at 12 o'clock, and that really maintains orientation. So for example, looking at the left main, you see that with the scissors, we go on either side of the left main, leaving about 2 millimeters of tissue on both sides, and then connecting both these cuts beneath the left main before we separate it from the base of the aorta. And you can see the suture at the top of that coronary. I always use 5 sutures to expose an aortic root, 3 on top of the commissures, and 1 for each coronary. And then we separate the aorta from the coronary. We try to stay away from the coronary ostium itself, and just follow the base of the aorta to separate the coronary from there. We do the same thing on the right coronary. You see both cuts linear, leaving about 2 millimeters of tissue around the ostium, and keeping it in a rectangular shape with that suture at 12 o'clock, and that will really maintain orientation of the coronaries at the time of reimplantation. Remember, what we try to avoid is any tension, torsion, or kink of the coronary. And then the next step, again, with low-grade bovie, we just separate at the base of the aorta. We're not burning anywhere close to the coronary artery itself, and that is plenty enough mobilization for the right. Just over the level of the right coronary, of the right ventricular muscle right there, and that will separate the coronary artery enough to make it ready for reimplantation later on. And then the next step is harvesting the autograft. So you see the assistant is pulling with a sucker the heart down, and that makes the pulmonary artery very straight. And we make the initial cut just proximal to the right pulmonary artery. And then we just follow in a straight line, knowing that the left PA is always more distal than the right PA. So using the right PA as the reference point is always a safe way to do so. Once it has been transected, that traction of the heart down is released. And using cautery, what we do is we just undo that connective tissue behind the PA enough so as to lift it off the plane of the heart completely. So you see with the forceps, we put some tension on that tissue, and with the cautery, you can just separate that tissue loosely. And you can see the ostium of the left main posteriorly that's sitting right there. And as you release that tissue, it lifts the PA up from the plane of the heart, and it pushes the left main and the LAD completely posteriorly and away from the pulmonary artery. You see, the bovie goes all the way down to the base of the heart until you see some of that muscle, infundibular muscle there at the base of the pulmonary artery. And you keep undoing that, that loose, fatty, and connective tissue in the back. The forceps always keeps that tissue under tension, and you always try to keep the coronary structures behind the forceps so that you always know that you're in safe territory when you're using your bovie. You see the coronary there in the back, and the PA keeps lifting up from the base of the heart. This is probably the one step that makes most adult surgeons a bit more nervous about doing the Ross procedure. For congenital surgeon, this is really something that they do much more regularly. Once you've reached and you see that muscle in the back, and here I'm just demonstrating the left main and the LAD in the back, you see it's completely safe, and it's actually very difficult to injure that. And this is the LAD laterally to the PA. In redo situations, it can be a little bit closer, but in first-time operations, it's a little bit away. And then the next step is examining the leaflets, making sure that we have a tricuspid pulmonary valve, that the leaflets are normal, that there are no major fenestrations. And as you can see here, this is a totally usable valve. The next step is poking a hole in the RVOT, and I go just about 5 millimeters below the nadir of the anterior leaflet. And with a right angle clamp, you just cut across there. And what I'm doing with the pen here is just illustrating the position of the insertion of the cusps once we've done that. So that opening in the RVOT is well below the insertion of the leaflets. And then taking a 15 blade, we just cut in a straight line just to enter the right ventricle. And then the rest of the dissection will be done under direct vision, where we can see the insertion of the leaflets, and we just follow that line with cautery on the outside, on that fatty tissue on the outside, and with scissors on the inside, until we reach the septal muscle. So you see here it's full thickness, and we remain about 2-3 millimeters below the insertion line. And then once we reach posteriorly, this is septal interventricular septum, and you can see that the scissor is only cutting partial thickness bites. This is the area where the first septal artery lies. Once you've connected both edges of this suture line, then with the cautery, we simply lift the autograft off the base of the heart posteriorly, staying in a horizontal plane parallel to the floor, and that really keeps everything safe in the back, and it keeps the first septal artery also safe. So as Dr. Da Costa will tell you later and in the discussion, this can be done in a very systematic fashion. There's no reason to rush through this step. It can take 10 minutes, it can take 20 minutes, but importantly, just by knowing the anatomy and by going very progressively, it can be done very, very safely, as you can see here. Once the autograft is harvested, as you can see, the final step will be to set it up for the proximal suture line. And before I show you how to do that, it's important to realize that the aortic root and the pulmonary root are slightly different. The aortic annulus, in part of its circumference, is a fibrous annulus that has structure that provides structural support to the valve. The pulmonary valve does not have a proper annulus. Instead, you have the infundibular muscle that goes into the base of the PA. But once we've harvested the autograft, this muscle here becomes devascularized and does not provide any structural support to the pulmonary valve. So it is very important to do two things. One, to cut this muscle, leaving no more than 2 millimeters, rather than leaving a lot of muscle and sitting the valve in a supraannular position. And secondly, making sure that this valve sits in a subannular position so that the native aortic annulus serves as support for the pulmonary annulus. So I'll show you how to trim it. Once we've harvested, we trim it further to remove all that muscle, leaving really a minimum amount of muscle. and scalloping it under the commissures, as you can see here. And then when we implant it, this is just a visual that you see the pulmonary annulus goes below the level of the aortic annulus itself. I like to use interrupted proline sutures, and it's important to make sure that the commissures are symmetrical when implanting it, because they're usually at around 120 degrees on the pulmonary autograft side, whereas in a bicuspid or unicuspid patient, the raphase and the commissure are not always symmetrical to each other. So pay careful attention to that. Otherwise, we may end up with a bit of prolapse and an eccentric jet of AI. I'll just skip through this, but just to show you to illustrate the sutures, these are single interrupted sutures. And the principle is to exclude all of this infundibular muscle. So you see the sutures go right at the insertion line of the leaflets. And on the aortic side, they go very deep in the LVOT so that we can really bury the autograft inside the aortic annulus or underneath. And you can see here, they go right at the insertion line. All interrupted sutures, usually about 12 sutures per sinus. So they end up being a lot of sutures. But once you have a system, it is very easy to manage the sutures as you go along. Again, right at the insertion line, so as to exclude that muscle completely when doing the anastomosis. Once that is done, the autograft is lowered into position, and the sutures are tied one after the next. As I said, subannular placement of the pulmonary autograft. The next step is coronary reimplantation. The coronaries always want to sit within the body of their respective sinuses. So I put 3 traction sutures just at the commissures, as you can see here. And by putting some tension on them, it makes it flattens the sinus of Valsalva. And I just cut a hole in the left sinus there and reimplant the left main button using 6-0 proline. There's nothing very particular about this. And then once that is done, we tie that suture. And the same thing is done for the right coronary artery. It always feels like it wants to sit high, but it always sits very naturally within the body of the sinus. And then it is also implanted using a 6-0 coronary proline suture. And then before we finish the aortic anastomosis, we shift our attention to the right side. I like to systematically oversize the homograft. We use cryopreserved decellularized pulmonary homografts using sizes 28 to 30. And it's important to try to avoid any purse shrinking of the distal suture line. This is the homograft. We've implanted in anatomical orientation. So you see it sitting here, and I just marked the lateral and the medial aspect of the homograft. And then I like to start with the distal suture line first, hence the importance of having the cross clamp as high as possible and the arterial cannulation into the aortic arch, because it really opens that space for the distal suture line. This is a running 5-0 proline suture. And then we complete the anterior surface of this anastomosis. And then we do the proximal suture line. And in this medial aspect you see here, this is the first septal artery. We can actually see it, which is rather uncommon, but in this case, it was quite superficial. And so the sutures have to skive through that muscle in order to avoid catching that first septal, whether you see it or not. This is a 4-0 proline suture with a big needle. And you can see the sutures are partial thickness through the muscle to avoid injuring that first septal artery. And then we finish that suture line anteriorly, as you can see here. And then we shift our attention back to the left side, doing the distal suture line. And the main principle is to cut the PA just above the commissures, leaving no more than 2 millimeters of PA tissue to avoid any supracoronary or supracommissural dilatation of the PA. I am very liberal at using a Dacron graft anytime there's a bit of mismatch between the aorta and the PA, or anytime the aorta is more than about 36 millimeters. I usually use a very short 26 or 28 millimeter Dacron graft to stabilize the sinotubular junction. And again, commissural symmetry is very important for that anastomosis as well. And so, as I said earlier, trimming the PA, you see these 3 sutures are right above the commissures, and I will remove all of the PA tissue just above these sutures, which makes it very close to the coronary implantation. So this is a curved scissors that I like to use to just run it just above the commissures so as to eliminate all of that supracommissural PA tissue. And then you complete it on the other side, as you can see here. In this very case, this patient had a hemi-arch replacement, so we'll use that Dacron graft after we put the markers at 3, 7, and 11 o'clock, which correspond to the 3 commissures. And then I just run a 5-0 proline suture right there. In terms of stabilizing the sinuses of Valsalva, Amin mentioned earlier blood pressure control. It is very important for at least the first 6 months to keep the blood pressure, the systolic, under 110 to 115 millimeters of mercury. And in patients who have aortic regurgitation, we need to be even more aggressive in terms of stabilizing the autograft root. I like to use a annuloplasty technique with replacement of the ascending aorta and a loose jacket on the outside. The annuloplasty is very similar to the proximal suture line of a David procedure. These are 2-0 ethibond pledgeted sutures placed on the inside along the basal ring. And this is what it looks like once the ring is placed on the outside with the autograft on the inside. But if we look at the steps, the sutures are placed after we've dissected the root all the way down to the basal ring. We place these sutures from the inside to the outside. These are 2-0 mattress ethibond pledgeted sutures. We place them along a horizontal plane under the 3 commissures and under the 3 nadirs. Here, just below the right and non, we go just a bit higher to avoid the conduction tissue. And then we take a ring from a Dacron graft. The size of the ring depends on the size of the pulmonary autograft annulus. We do pulmonary annulus diameter plus 5 to 6 millimeters. The sutures are then passed through that ring. And then the ring is lowered into position and tied around a Hagar dilator, which is the size, which corresponds to the size of the pulmonary autograft annulus. Once that is done, we have a aortic annulus that's very stable. And the last step is using this aortic jacket. We keep the native non-coronary sinus wall and the left-right commissure, and I tack them to the Dacron graft distally. And this is what it looks like once it's done. You see the aortic jacket there of native non-coronary sinus wall, which I don't split, and then the left-right commissure there, and that sits on the outside and provides further support for the sinuses of Valsalva in all patients with a ROS. And you see what it looks like here once it's completed. So once again, I hope this was just a brief overview of the technique, but I hope it was helpful. Thank you very much for the invitation, and I look forward to a very interesting discussion at the end.
Thank you very much, Dr. Elmahansi. Again, excellent presentation, very clear. All the video was perfect. And now our next speaker is Dr. Eduardo Turner. Can you see the screen?
Yes.
Yeah. Turner, please.
Okay. How are we going to go and move the slides backwards and forwards? Are you going to move?
I can move it, please. Yeah.
Okay. Can you hear me well?
Yeah.
Right. I twisted a little bit the title of my talk into why do we need to do the loss operation in this country, in Chile, or perhaps anywhere else in the world? Background, lessons from the learning curve, what are our local results? The Empire Strikes Back, I'll tell you about it later. The current situation, looking into the future. I'll be brief. I'll just echo on many things that Amin said before. The next one, please. Juan, can you give me the next slide? Okay, this is taken from Rob Kinsley. He was the head of cardiac surgery in Johannesburg in the 80s. at the height of apartheid South Africa. And what he did, he published a paper comparing results of mechanical valve replacement in patients on the first world population, South Africa, basically white South Africa, and third world, which was Black South Africa. And as you can see here, patients from third world or poor patients usually do much worse with mechanical valve replacement just because they don't have access to good medical care. And if we're going to be honest, in our Latin American continent, this happens a lot. Perhaps the gray area is much bigger than what it is or what it was in South Africa at the time. And it has changed a bit in those days. The next one. And this is a, just to illustrate the point, this is a 22-year-old patient in whom I did a mechanical valve replacement 6 years ago. And he came to see me last Monday, 2 days ago, and showed me his anticoagulation chart. You can see November INR 1.3, December 1.2, 3 weeks later 6.8, and then it's 1. And then he told me he got fed up with it and decided to continue with the dose he had and came to see me, and his INR at 2 days ago was 1.1 again. I told him repeatedly about the importance of being careful with this thing, but I don't think he really listened. The next one. And now we have tissue valves, and there's been a constant increase over the last 10, 15, or 20 years in the use of tissue valves instead of mechanical valves. And the companies, some of the companies have told us that they now last 20 years at least. Well, this patient was 30 when I reoperated him. His original operation had been 10 years ago, so it's rather new. Pericardial valve lasted only 10 years and had to be reoperated because of aortic stenosis. The next one. So that's the background for the Ross operation. Now, Ismael, and I've spoken with Francisco before and some others, will try to tell you that it's a very uncomplicated operation, the Ross operation, which is, and some people call it a challenging operation, which I think is a bit of a misnomer. I think it's a very difficult operation with lots of little details that you need to get them right, because if you get them wrong, the patient will probably end up with a ruined heart or a ruined life, or perhaps even dead. Now, if you look at the bottom, separating the pulmonary valve from the aortic can be a problem. You can injure the left coronary, you can injure the left anterior descending. Ismael talked about the first septal, which you can damage when you are peeling off the valve from the right ventricular outflow tract. And then pretty much all what Ismael said. It takes a long time. You have to be very careful with hemostasis, and you need to have a very good plan for myocardial protection. If you don't do that, and then it's obviously not an operation that you can wake up one day and say, well, I'm going to do a Ross today. Either you do it all the time or better stay away from it. The next one. When we published our results in our local medical journal in 2010, we had about 130 cases, I think, with a 2.5% operative mortality. The next one. But in the midterm follow-up, what's interesting and echoing what others have shown, and Amin showed all the meta-analysis and things, the results are surprisingly good. Very few reoperations. On the autograft, it's been mostly patients who were operated because aortic regurgitation, and then we didn't do anything about the annulus, and then the autograft dilated. And this trend has continued up to this day. And what's quite surprising is how durable pulmonary homografts are, either cryopreserved or wet preserved. They seem to do really well, for the most part, for many, many, many years. The next one. Now, what I meant by the Empire Strikes Back is what some valve companies have done with surgeons in their payroll, where they have shown or they insist on the advantages of conventional tissue valve replacement. This is, and they have done quite an imaginative and manipulative marketing, both in the lay press and in the medical press. This has appeared in one of the local tabloids in the year 2008. And all it refers to is the first implant at one of the local clinics in Santiago of a sutureless valve. And they claim that it's going to be a permanent valve, and the patient will never, a 66-year-old patient will never require another valve replacement. The next one. But this continues up to this day. The next one. This is our friend, Juan, the next one, please. This is our good Latin American friend, Joe Bavaria, commenting on Paul Sturza's presentation at the last year's AATS. And what Joe says here is you have a patient who is otherwise a very good candidate for a Ross operation. Instead, put a brand new tissue valve, and it's going to be a 15-year valve. And then you put a TAVR in, and then you get another 8 to 10 years. But this is something that we've been hearing from some of the companies of the durability, of improved durability of tissue valves. They have improved, and yet it's never proven true. Valves, tissue valves, despite what you do to them, tend to last pretty much the same that they did with the first valves 30 or 40 years ago. In addition, Joe went on to say that you can get a 1% mortality rate for a redo aortic valve. But yet, if you read the paper presented in last year's ATS with the database of the STS database, operative mortality for the redo AVR was 4%, and 10% of the patients required a permanent pacemaker. And the next one, just to finish then, if we think that this Ross operation is the best operation for a young patient, we need to have a good supply of homographs. And this is something that we've been lacking at present. And perhaps the other panelists would comment on alternatives to the pulmonary homograph. I, for the time, tried using stentless valves, but results were very poor. Most of them developed gradients very quickly after surgery, so we had to abandon them. So you want to do this operation, you need to have an ongoing supply and a good supply of pulmonary homographs. We need to educate ourselves, we need to educate our patients, our referring physicians, and cardiologists regarding problems and advantages, disadvantages of conventional valve replacement versus the Ross operation. Regarding training and collaboration, I think this webinar is a wonderful starting point. We saw excellent videos from Ismail. That's something that we need to work in. We need detailed videos with pay attention, just like Ismail showed, to all the little details of this operation, and perhaps ongoing discussions regarding what's best for a particular patient, advantages, disadvantages, etc., etc. And then finally, we need public results, which is something that you see a lot in the Northern Hemisphere, but not in the Latin American continent, so that people and patients can choose where to go and have an operation. That's all what I had to say. Sorry for all the inconveniences.
Thank you, Dr. Turner. This is the Chilean experience. Dr. Turner, as I said before, is the only cardiovascular surgeon in my country who performed this procedure, and he has really good results and outcomes, but he has some issues with the homograph. Finally, and our last speaker is Dr. Francisco da Costa, and he's going to talk about how to build a Ross procedure program in Latin America.
Thank you very much. I think I will share my screen here with you. Okay, can you see the presentation?
Yes.
Yes?
Yes, we can.
Okay, thank you. So thank you very much, Juan, for the invitation. It's always a pleasure to be with such a distinct panel and discuss the Ross operation. We have seen Amin and Ismail talking about the Ross, how good the Ross is. The problem, as Eduardo said, to do a program of Ross in South America is not that easy, and we have some challenges to progress. So I will, as I go through my talk, we're going to talk about to identify the local needs for that operation. I think the surgeon has to have the vision and desire, a real desire to develop that program. You have to prepare yourself for that. Ideally, if you can find a mentor. You have to build a team, a very strong team, case selection in the first phase of your operations. Then you have to document your results. You need to have a clinical database. You have to demonstrate and publish these results, and if possible, after some time, also contribute with some improvement and innovations in the field. Here are my conflict of interest. I have a patent on desolarization technique, which we're going to talk a little bit about it. And I'm owner also of a company called Cardioprotese, which produces biological valves here in Brazil. So when I went to the US and I came back, that was back in 1988, I had to see what were the local needs and the demand for the operation. And that was easy at that time because there was no ROS operation in Brazil up to 1990, up to 1995. There was just a single case performed, and then we started in 1995. But when we look at, let's see how our patients are. So this is a survey of 78,000 patients operated in São Paulo, a big center. And if you look at the demographic of our patients here in South America, it's very different from what you see in North America and Europe. So if you look at this table one here, you can see that in contrary to the developed world, we have a very high percentage of young patients who need to have valve surgery. And rheumatic disease is still very prevalent. 42%, 53% of the patients were rheumatic patients, which is very high. And if you look at the results of valve replacement, you're going to see that long-term results with conventional valve replacement in South America is not very good at all. Oops, for some reason it's not going. Okay. So here is another paper from São Paulo, from INCOR Institute, with 323 patients operated with mechanical valves. And you can see again that the results, the long-term results of survival with mechanical valves in this patient population is very poor. 10 years after the operation, at least 30% were dead. And also the thromboembolic complication is higher than expected in other countries. And if you look also at the profile of the valves implanted in our country, you can see that even in younger patients, you have a very high incidence of bioprosthetic valve implantation instead of mechanical valves. And that's because, as Eduardo said, anticoagulation is a big problem. You can see a patient like this that comes from very distant rural areas in the country. So there is no way that those patients will perform or can do a good anticoagulation at all. Okay, but so if you want to do the ROS operation, I think you should prepare yourself very carefully before starting the program. So start by analyzing and understanding the aortic root, see how the coronaries relates to the RVOT and the infundibulum, where the septal is, try to understand all the anatomy of the base of the heart, which is very important. And ideally, if you can, the ideal surgeon to start that is a surgeon who has some experience with aortic root operations, with David operations, and also with aortic homografts and bentals, which is already helpful. And as Ismail said, you should note that there is differences between the pulmonary valve and the aortic valve, how it relates to the annulus and the muscular, which supports the cusps in the pulmonary autograft. This has consequences on how you should do the operation, the ROS operation, in a perfect way. And then you should also know that there are many ways to do a ROS. You can do the ROS as a subcoronary implantation, as an inclusion technique, as a full root replacement, and there is many details, different details between these different techniques. So you should be really aware, and you have to choose. In my opinion, you have to choose one type of operation preferentially and go straight forward with this choosing technique that you have done. And you have to pay attention to details. Ismail also shown that. For example, when you have a mismatch between the diameter of the pulmonary to the aortic root, you need to shorten here the aortic root. We did that, as Tyrone said in the beginning, just with a strip from running from trigone to trigone. I think today you should be more aggressive and do a circumferential annuloplasty, because the stabilization of the annulus with this technique is much better. And also you have to see the mismatch between the ascending aorta and the pulmonary autograft. Here, very short. If the aorta is not too dilated and the quality of the aortic wall is good, we make an aortoplasty to make this anastomosis very nicely. Or if the aorta, on the contrary, is very enlarged and or the quality of the tissue is poor, then we replace it with a Dacron graft, replacing the aorta, the ascending aorta, and sometimes the hemiarch as well. Then you need to find a mentor. And I was lucky because I had very good mentors, especially I didn't have too many contact with Sir Magdi Jakub, just in some meetings, we could have some talk, but I have very deep conversations, first with Dr. Albert Pacifico in Birmingham. We were working at Kirkling's place at that time, that was back in 1988, and Tyrone has been, he's a Brazilian friend, and he has been so kind to teach us many of the details. So if the surgeons wants to do a ROS operation, I think you should use your time, talk to these guys, because they will give you very useful advices on how to do this operation. And you also should make a strong team. To do a ROS is not just a surgeon. I think you have to have nice cardiologists, echocardiographers, intensive care, anesthesiology. Everybody is involved if you need to have a real serious ROS program. Okay, so we came from the US in 1988. We saw many homograft operations. We saw many ROS operations. And we wanted to start, but then you say, well, we need a tissue bank, which Eduardo already said. I mean, that's a problem in South America, and it's not common. So it took us from 1988 to 1995, 7 years, to have homografts and to start a ROS program. The first homographs that we got, one of our surgeons went to London and brought in his suit, in his bag, 6 homographs, and we started implanting some homographs. And they donated for us this very old nitrogen liquid tank, but it was not so useful because we didn't have the other things. So we started with fresh homographs, just with antibiotics in 1995 and 1996. So in 1996, when one of our visits to the Toronto General Hospital, my wife, who was running the tissue bank, she went to the Sick Children Hospital just in front of the Toronto General Hospital, and we got a donation from them from a controlled rate freezing system. And afterwards, Fundação Banco do Brasil also gave us some financial support. So then between 1996 to 2000, we could build inside our OR. We had a reasonable quality to process heart valves and cryopreserved homograft bank. And finally, after some years, we could make an arrangement with the university, and we got the whole building here, the 3rd floor, just for the tissue bank. And then by that time, finally, we had, I think we have a international quality tissue bank, which makes cryopreservation of heart valves, pericardium, and also other things. So that's very important, and it's not easy to develop in South America. That's very, very difficult. Well, when you start to make the ROS, I think you should be do very carefully. You need to have very good results. So in the first 20, 30, or 40 cases, by the time that you're not very used to the operation, I think you have to make a very good case selection. Try to make just on patients who have need isolated AVR. They should have preferentially a normal annulus and an ascending aorta, normal left ventricular function. Try to make the ROS in the patients who will benefit most from avoiding anticoagulation. Avoid complex reduced or infective endocarditis and patients who have no comorbidities. After you have 20, 30, 40 cases, then you can start moving on. Why that? Why it's so important to have good results when we start that? Because at least that was my experience. When you start a ROS program, many cardiologists, surgeons, everybody, they are against the ROS. They are against the idea they will come to you and say that this operation doesn't work. And at that time, we had many bad reports about the ROS. Should we still do the ROS operation in adults? I mean, the aortic valve guidelines recommended a class 3 for some cases, and about the reoperations also very bad reports saying that the ROS should not be done unless only in children. So you really need to have good results in the beginning to try to convince your peers that this operation is worthwhile. So what you should do as well? Well, we made like 4 or 5 international symposiums, and we brought the good guys here. Tyrone came here 2 or 3 times for our international symposium. Here is Blaise Carabillo as well in the audience. So then you start making some good common sense about the ROS, and then by that time now in the last few years you have some good reports about the ROS, and what I can tell you is that if in the beginning is difficult, then people start convince themselves that maybe you can do the ROS, and after some time it's really amazing, because if you go to the pediatric hospital, for example, they say, well, I will send you the patient just if you do the ROS, otherwise I will still keep the patient in medical treatment. So then you really give you have a more big support for doing the ROS. But as others have already said this today, I mean, to do a ROS operation, you have to have at least a minimal work, at least preferential, at least 20 to 30 cases every year, and the ROS should be performed just in reference centers really dedicated to the operation. And that was, we just published the long-term clinical results on the JAMA cardiology. And if you look at the editorial comment by Robert Bono, they talk really good things about the ROS operation, that you should be doing the ROS operation in reference centers, but they emphasize here that these results could only be replicated in centers who do the ROS operation, and probably not replicated in small centers. So I think that's very important. The other thing which I think is really important to do the ROS center is you need to have a clinical database, and you have to have a dedicated follow-up for all those patients. So we have a series of papers, paperwork that we do for every ROS patient. I personally try to schedule every single patient to come to my office every year. Of course, we cannot have all of them coming, but we go afterwards, after those patients in an active manner. We have a dedicated secretary just to follow homografts and ROS operations. And we have also echocardiographists and cardiologists to optimize the medical treatment and to make a very good and precise echo evaluation, because this is another problem. If you look at the echo data from outside, they are not always very precise, and you can have some mistakes when analyzing your results. So as soon as you start to have your cases, as soon as you have your database and all of these things working, I think you should start publishing, and you should actively go to meetings and make presentations. So then your program starts to be known by others in your local community. So publications on your own results, I think, is very important to give that support. And finally, after 200, 300, or 400 cases, you start to having some ideas, and you start to try to contribute to the literature and to the progress of that operation. So we were personally involved in the desolarization technique of homografts. These are fresh allografts with no cryopreservation that we can storage up to 6 months in reality at 4 degrees. And we could see, we could see over time that those, we made this immunological study in 20-some patients, and we saw that the immunogenic reaction was much lower in the decellularized allografts, and this has been coincidental with very low levels of calcification, and the gradients over time, as the time passes on the cryopreserved, on the decellularized allografts is much less when compared to the cryopreserved. Those allografts does tend to shrink, and they do not calcify. We have a very good evaluation by CT scans in many of those patients, and we have published these results. Furthermore, following the idea of Hans Sievers, we started to make decellularized allografts. Here is the pulmonary allograft, but with an extension of decellularized pericardium from the same donor. And that's what we do here. You can see the result of this thing. You can, with the decellularized pericardium, you can have a much wider opening to suture to the RVOT, and you put the valve away from the suture line, because I'm convinced that some of the insufficiency and some of the stenosis that you have is because the valve itself is very close to the suture line and subjected to fibrosis and stenosis on the long term. So that's what we saw. Here is some of the CT scans on those decellularized extended allografts, and you can see that on the normal allografts you have the gradients rise up in the first 1 or 2 years and then stabilize, but if you have extension, this rise is much lower, and the grafts are more stable over time. And finally, during these times, we have difficulties in getting more homografts due to the pandemic of the COVID, and also because of other problems in the country. So we have somewhat of kind of shortage of homografts. So I think in patients which are above 35 to 40 years of age, here is the solution that we find for some patients that are being operated in private hospitals. We have a decellularized bovine pericardium conduit. Here's the valve inside. There is no stent, and these are providing very good results, at least up to 2 years. And we are also controlling with CT scan and echo. We're not seeing calcification. The gradients are very good. So better to do that than not to do the ROS at all. And if you do all those things, you're going to be maybe rewarded sometimes in some nice meetings. That's a pleasure for us who are surgeons. And we don't have time here to discuss our results, which have been published in many times, but our mortality, our initial mortality right now is around 1%, so it's very reasonable compared to mechanical valves. And we have published that our long-term survival up to 15 to 18 years were similar to the general matched sex and gender population. And now we are working on the 25-year survival of the ROS procedure. It seems that after 20 years, maybe the survival will not be exactly similar to the matched population. We're analyzing these results. We're making a study to understand if the results of the ROS operation in rheumatic patients are similar to patients with bicuspid aortic valve. This paper is almost ready by that time. I cannot comment on that at that time, but survival is still good, 78% at 20 years, and close to that at 25 years. So we were still pretty happy. And besides, late mortality, at least in our series, around 50% or a little more is from non-cardiac origin and non-valve related. So I think we're still very happy with these results after 25 years. Here is an interesting case that we operated like a few months ago. This patient is a lady, by the way. She's now around 50 or 55 years of age. The ROS was performed at 22 or 24 years ago. You can see that she came with an aneurysm of the ascending aorta. We had to replace the ascending aorta and the hemiarch here. But the autograft itself, it's funny, you can see here the sinotubular junction with no dilatation and the cusp perfectly aligned 23 years after the operation. So it's really nice to see results like that. We have a patient here, is our patient from the very first patient that we operated in 1995. He's still alive. Some young patients. This little girl was operated with 2 years. Now she dances ballet, and she's a teacher also with 24. As patient number 7. So in conclusion, I think to develop a ROS program in South America is a long, challenging, but rewarding process. You should be committed to build a strong and focused team. Ideally, one should be willing to perform at least 20 to 25 cases per year. It's not an operation that you do once in a while. Build a strong database, publish your results, and although your clinical cardiology may be skeptical at the very beginning, they will gradually recognize the merits of the ROS operation and start to refer more and more patients to you. Thank you very much.
Wow, amazing experience. Congratulations for everything. Sometimes to develop everything in South America is more challenging than North America. Congratulations for your great experience. In order to continue our agenda, now we're going to start with the question. And for that, Dr. Juan Carlos Ramondes, he's going to start with the first question. Juan Carlos?
Hello, thanks a lot, Juan, for your kind invitation, by the way. And congratulations for all the speakers and the splendid talks you gave to us. And special regards to Eduardo, as we recognize him as a national ROS leader surgeon. First question, if you notice in the chat, is a long one. I think it might be answered by Dr. Ismail, if you want to. If you are a young surgeon who wants to learn to carry out the ROS procedure, what would be the path to follow? Are fellowships in North America? Are acceptable numbers? Where are the teaching surgeons for the ROS procedure?
Yeah, I think that's, thank you. I think this is, and I think I'm sure that Francisco and Eduardo may have some thoughts as well. And by the way, congratulations on both these talks. I thought they were really spectacular and really laying the ground as to how to start a program and the realities on the ground. Sometimes I come from Egypt, so I know as well the difficulty sometimes of having access to homographs and you know, careful ICUs and all these things that come into really making a safe and a good ROS program. But to try to answer that question, I think Francisco really answered it very, very, very eloquently in his presentation. I think you need to try to identify a mentor, to dedicate, you know, a part of your training, or after your training, a year or two or more. I spent 4 years with Professor Yacoub in London. You can spend less time, or Francisco spent time with Dr. David. That really helps in not just understanding the steps of an operation, but really everything that comes around it, and the whole philosophy and the approach to aortic root surgery. And then you can go back and start laying the ground for a program, just like Francisco explained it very, very clearly. And like Eduardo proved it in Chile, I think it can be done. I'm certainly not the best person to explain how it should be done in South America, but I think starting by identifying a training center, and there are many, or I shouldn't say many, there are some centers at least that perform a regular volume of ROS, but I think more broadly, it's aortic root reconstruction. So it should be somewhere where aortic valve repair, valve sparing, and the ROS are being performed, because they all fit within a continuum of aortic root surgery. At least that's my impression of how this should be done. But I'd be curious to hear what others have to say on the panel. Francisco, I think you're muted.
Okay, just to add what we have already said. Today, I think you have more ROS surgeons in the world. Some spread in some places, and you should take a young surgeon that goes to a place and stays at least 6 months or 1 month, 1 year, just learning all the details, and he will succeed. I think, but it's very important to have a mentor and really to be dedicated to that, because it's a very nice area of surgery. And if you like surgery, you don't like to be just doing conventional valve replacement. I mean, it's a challenge for yourself as a surgeon, so it's very nice.
May I add something? I think it's easier said than done, though, because the Ross operation now is done in less than 1% of the aortic valve replacements in the world, I think. So it's more like a boutique operation. So there aren't too many opportunities for training to go and assist someone and see how to do it and go through all the details.
And another problem that we, oh, I'm sorry, I think Ismail is talking. Ismail, you're mute.
You go ahead, Francisco. I'll go after you.
No, I think another challenge that we have nowadays on the times that everything is becoming minimally invasive. The patients come to you and they know about the ROS, and everybody asks to you, well, doc, can you do that through a minimally invasive operation? So that's another obstacle that you have to overcome, you know, because patients are always trying to have more minimally invasive operations and on the cath lab as well. So you really have to have nice arguments to convince them to go to a full sternotomy and to do a ROS operation.
Yeah, I think that's definitely a good point, Francisco. But I think, you know, if we think in broader terms about what the role of open heart surgery will be in the next 15 or 20 years from the aortic valve standpoint, the transcatheter approaches will become more and more relevant for the older patients. And I think where our real role as surgeons the differentiating role of surgeons versus just transcatheter approaches will be in these younger patients who have many years ahead of them. Because as Amin showed very eloquently, nothing will replace the biology of a living valve in that position. And the ROS really stands out. And however much they ask for small incisions or things, I always tell them there's the short term and then there's the long term really plan. And the younger the patient is, the more I'm concerned about the long game. And nothing matches the results that have been published over and over and over again in the last 10 to 15 years or so. So it is true, I think, that less than 1% of operations are ROS procedures. It's a very boutique operation. I will, however, say that in the last decade, there have been more and more centers that have adopted the ROS and have implemented ROS programs. In Canada, there are now, it went from a couple of centers to at least 7 or 8 centers that are routinely doing it now. In Europe, there are an increasing number of centers. And in the US, there's an increasing number of centers. Next Monday, for example, literally in 5 days, I will be at University of Pennsylvania to help them start their ROS program. In Chicago, I was a few months ago to start their program as well. And so many centers now, based on the evidence, are starting programs. So, I think there's an opportunity for young surgeons to jump on this opportunity of being, of really focusing their practice into aortic reconstructive procedures. And we haven't even approached the area of aortic valve repair, which is also which is a field that will expand and grow in the future for these surgeons that will really dedicate an interest to aortic root surgery. So, I think that there is definitely room for learning these things, but as Francisco said and Eduardo showed, you have to really be dedicated to it. You can't just casually do it once or twice here and there. It really has to be a big chunk of what you do and what you think about day and night.
Alex?
Yeah, well, thank you very much, Juan, for inviting me to this webinar, and thank you very much for the speakers who were great talks. I have 3 questions. One is, and you can answer all of them. Any one of them can answer the questions. One is, I agree with Dr. Costa that this size of an operation, when competing against TAVI or mini AVR, starts with a problem. But I think the real problem for us in South America is the scarcity of the homografts. I mean, we definitely don't have it. I think we should do a reality check. And today, I don't know if any other company other than CryoLife is selling them in the US. And we have been having talks with another part of CryoLife for them to help us with the know-how and with the graphs. But that hasn't even started yet. So if you had to, do you think there's any alternative to the homograft? And going to one of the questions from the attendees too, one is asking them, what do you think of the Contegra valve in the pulmonary position? So that's one. The second one is, I was helping Gustav Pedersen 13 or 14 years ago to do reverse Rosses. So he was putting the pulmonary valve back in the pulmonary position and putting a homograft in the aortic position. So a patient is 20 and he or she is coming back at 40 and getting a homograft in the aortic position. What would you do today? Maybe that you're doing something else. So the question is, what are you doing today when the ROS fails 20 years after the first operation? And the third question is, what is the oldest patient with a perfect anatomy in which you're doing a ROS and not an tissue AVR, maybe, or a tissue AVR probably? That's for the three of you, and you can answer any of them.
And what is the youngest?
What is the sorry. What is the oldest patient you would do a ROS and not an AVR? So if you're doing 60, 65, 55, when do you say, you know what, this patient benefits more from a regular AVR and not a ROS anymore, with a patient with a perfect anatomy for a ROS?
Well, I think I can go first. We do the ROS, or we consider the ROS in patients up to 60 years of age. Our oldest is 63, if they have a life expectancy of at least 20 years. So if the patient is in good shape and has that life expectancy, we would discuss with him the ROS operation. And as a matter of fact, all our sub-analyses that we did, the best patients to do the ROS, our best results are middle-aged patients. That means between 40 and 60 with aortic stenosis. In these patients, the valve, the autograft rarely fails, and the homograft is very durable at that age. So you don't have reoperations on that. So it's really nice. So for us, it's 62 years of age.
Okay.
And answering your question about the homographs, which I think is very important, Ismail is a lucky guy because he can put 28, 30 millimeter homographs in everybody. We have the homographs bank here, but I don't have 28 and 30s for everybody. We have 23, 22, 24. So that's why we have to make those other modifications, increasing the length and the size of the homograph. And also I think that for patients above 35 to 40 years of age, a decellularized valve or a valve who has a very good anti-calcification treatment, I think we can have acceptable results. We have to follow those patients, but on the experimental setting, decellularized bovine pericardium, even in the mitral position in the sheep model, were very, very resistant to calcification. Of course, we have to wait the results in human patients.
And what are you doing when a ROS fails? What is the operation then?
We try to do a David operation if the cusps are good. You can do that in around 40 to 50% of patients. Otherwise, most of our patients, they ask for a homograft, which you can do because most of those reoperations comes after 15 to 18 years of the initial operation. The patients are happy with a durable biological solution, and they ask for another biological solution. So then we offer a homograft, and if you cannot, then you have to choose between bento, mechanical, or biological bento. I don't know what Ismail thinks about it.
Yeah, I agree with everything you said, Francisco. And we offered the ROS systematically up to the age of 60. What we have to remember is that the conditional life expectancy of a 60-year-old in North America is to live up to 86 years of age. So if they have reached age 60, they're actually expected to live another 25 years. There's not many biological valves that will last 25 years. So if the patient is actually healthy and active, it doesn't, and in their 60s, I will propose a ROS to these patients, not as much because of the survival benefit that Amin spoke about initially, but rather for the hemodynamics and the durability of the valve. The durability, it's almost a definitive operation in patients who are over 50 or 55 versus a biological valve, which inevitably will show some signs of degeneration, although patients may not have a reoperation because they get too old, but the valve will definitely not be working very, very well 15 or 20 years down the line. So I think my oldest is about 68. 2 days ago, I literally did a 67-year-old patient who had isolated severe AS. She's female. She kayaks every day in the Hudson River, and her dream is to go around the Manhattan Island. So we just, I think that from hemodynamics, and she had a 20-millimeter annulus. The alternative would have been to put a freestyle stentless route for hemodynamic purposes, but I think an autograft is much more durable than that. And as Francisco said, we're lucky enough to have, the homografts readily available, so we can afford to use them in 67-year-olds, as well as, without punishing a younger patient from having a ROS and a good homograft. In terms of alternatives, I think, Eduardo and Francisco are much better placed to say about it than I would. I would have said stentless, but the Chilean experience seems to be a bit unsatisfactory or disappointing with the stentless routes, but I guess maybe the bovine routes or otherwise are good options. And when the patients come back for reoperation, a valve sparing is what you try to do if the reason is autograft dilatation, but sometimes it is primary valve failure. And in these cases, we just replace typically with a tissue AVR, because these patients are, part of the choice of the ROS initially was also to avoid anticoagulation, and they're still in that frame of mind. But, hopefully they're 20 years older or so, and so a tissue valve may not perform so badly at the age that they need a redo operation.
Yeah, the sad thing around here is that homographs or pulmonary valves, for that matter, are basically going to the dustbin. They're not being harvested for homografts, and that's very sad, because it's the best by far option for the right side of the heart, regardless if it's a homograft or it's a congenital case. Now, maybe Ismael or Francisco, someone else in the panel, why are the companies not making stentless pulmonary valves, for example? Maybe Roberto can say something.
What did you ask? Sorry.
Alternatives to the homograph, Roberto. Why not a stentless pulmonary valves? Why are the companies?
I think the best alternative for a pulmonary valve is another pulmonary valve.
Yes.
We know that from Fallot operations. There is no better valve than a homograph, which is a pulmonary homograph. So that's it. But I have two questions that they were written there. Before, I want to comment that when we started in 1985, we operated up to 67 years of age. We presented an abstract in the AATS where after 50, in that group, patients after 15 years or 20, they start dying of other causes, because life expectancy in Argentina is not like in Europe or US. You have to consider that. That's why we decided to do ROS in young adults, unless rare exceptions, people who are very active. Here we have an obese population who is increasing. We don't do any ROS in obese unless he decreases weight. We are very selective, and selection is very important. We did the ROS in that period up to 67 in redos. They are quite challenging sometimes when you do a second redo ROS. But the thing is, so we're limited today to 18 to 50 years, unless the patient is like some very active sportman in very good shape or women. I wanted to comment that that's what we are doing. But the limiting factor is homograph. Sometimes we have had patients waiting up to 8 months for a homograph to appear. For women, it's easier because they are smaller. But sometimes if the patient doesn't feel very well, particularly in aortic stenosis, we have to put biological valve. So here where we are, home is a problem and there is no better valve because there was an experience from El Khoury that they used freestyle in the right position. I don't think it's a good idea. I use it, it's still working, but after looking some works of Fallot and freestyle is not a good idea. But my question to you is, we know we can do the ROS. Reoperation is not a concern. We wrote a paper on that published in the Carval disease, the journal. But the problem is when you have to operate an asymptomatic patient with a ROS. So my question to all of you is, if you have an asymptomatic patient with a ROS procedure with an enlarged aortic root with minimal or no aortic insufficiency, when do you operate? And if the other patient is, if the root is okay, but you have aortic insufficiency. Both patients are asymptomatic. One, the problem is the root with a very good functioning pulmonary homograph, and the other patient is an asymptomatic patient with aortic insufficiency. The question is, in these two situations, when do you operate on the autograph? And the second question, in the asymptomatic patient with ROS procedure who has a homograph dysfunction, when do you operate when they have aortic stenosis or aortic insufficiency? So 4 questions.
I don't think there are any clear indications for autograft size, Roberto, and nice to see you in this panel. There are only a handful of reported cases of autograft dissection. I'm unaware of any cases of autograft rupture. So I'm rather liberal if there's no AI to wait on these patients. The cardiologists are the one who will put a lot of pressure because they keep buzzing, if it reaches 5 centimeters. But I think you can wait till 55 millimeters and sometimes even more if the valve is really competent. Typically, the valve will start leaking. So it actually is a good idea to go a little bit earlier because the chances of saving the valve may be better instead of waiting for long-standing chronic severe AI and then the leaflets get rolled up and maybe the valve sparing becomes a bit less predictable. For the primary AI, I indicated like any other asymptomatic patients based on LV size and function, provided they are asymptomatic. But you can also do a stress test just to make sure that they're truly asymptomatic. And you can also look at other factors like BNP and other things as such. For the pulmonary homograft, I think it's mostly looking at symptoms. Again, you can do a stress test to assess whether they're really asymptomatic or not. And then I like to use an MRI to evaluate RV size and function. And anytime it looks truly dilated or dysfunctional, early dysfunction, then we won't hesitate to intervene, either transcatheter or open on the right side.
Yeah, that's an interesting point because we have seen those patients personally and all of those patients. We could see that a diameter of 45, 46, 47 at the level of the sinuses after the ROS is somewhat common but stable. Those diameters tend to increase very, very slowly. And as you said, after almost 600 operations, we never saw a dissection on the autograft, and we are not aware of any patient who ruptured the autograft and died because of that. Maybe it can have one patient of sudden death. That may be the cause, but it doesn't seem to be the case. So again, we completely agree. If up to 54, 55, if the patient is stable, the valve is working well, that's fine. but the most common cause of indication is concomitant dilatation with AI.
Yeah, that's true. Most patients get redo for both, but the only one that I have the chance to do a Tyron David was one that had dysfunction of the homograph at 18 years, and there was dilation with minimal insufficiency. The others that have dilation, they have moderate insufficiency, but the leaflets were not normal, you know, they were more flat and they were thicker. So we couldn't save any, even though we wanted to save. So maybe you have to reoperate very early. It's very true that most cardiologists say, oh, the aorta is 65 or 60, but the only dissection that we have in more than 300 patients was in a patient that became very obese after the surgery, and he had a distal dissection to the homograph. I mean, to the autograph. That is the aorta dissect. So Paul Sterzel thought that in his lecture, he said he never cared about the diameter of the autograph because it's very unusual, the dissection. I want to tell you, we keep all patients with beta blockades for life. Frequency at rest has to be 60 per minute. And we tell them, and if they need, we use ACE inhibitors to keep systolic blood pressure between 100 and 110. And some patients in the immediate post-op, they have fever, apparently it's due to the homograph reaction. And some author has suggested to use non-steroidal anti-inflammatory drugs during the first month. My question is, if you have found that some patients have fever, and if you use any non-steroidal anti-inflammatory drugs during the first months.
With the decellularized homographs that we use here, there's no data to support using anti-inflammatories, but I keep them for 6 months after surgery. I give patients naproxen, a low dose twice a day. But if the patient, for any reason, whether because the blood pressure is hard to control or whether because they have some discomfort, stomach discomfort, we stop it. And in our most recent data, which we published last year in JTCVS in close to 500 patients, we didn't really see any impact of those who took it and those who didn't. But part of the thinking is that homograph stenosis, which can occur early, Francisco showed that early curve in some of the homographs. Maybe we can mitigate that with early anti-inflammatory agents, but I don't think there's any robust data to say that this is really a good idea. But we do it. Beta blockers, we also use it, but I like to get the patients off beta blockers after about 6 to 12 months. So in the initial period, I like to keep systolic pressures under 110. And then after that, I think that the autograft has adapted, the wall has changed. It looks more like an aortic wall, an aortic valve. And we try to wean the patients of all these medications unless they have, primary hypertension, but just to keep them, completely free of any medication.
In our series of young adults, which is mean age 35, 25% of these young people here in this country have hypertension, which is very high. I don't know if it's the same experience in young adults, mean age 35, that you have 25%, 1 out of 4 hypertension. Do you?
No, that's high. That's much higher than what we see here. They will be hypertensive in the initial weeks, but then everything settles back. But no, yeah.
This is pre-op.
Interesting. No, that's not our experience here. Definitely not.
So you talk about general population, Roberto.
No. We have young adults 180. Mean blood, they were hypertensive, by the guidelines, before the operation, 25% of the patients, half of the patients had aortic stenosis and the other half aortic insufficiency. So hypertension here in Argentina is a big problem. And I wanted to know if you have something similar.
Well, with the governments that we have, everybody will become hypertensive in very little time. But talking about dilatation, some people are supporting the use of rapid homograft, which I don't believe in that concept. I don't think it should be used. But I would like to ask Ismail what he thinks about Dr. Akar. He has proposed that we could use a bioabsorbable mesh around the autograft, and this mesh would be absorbed, but would create some kind of fibrous tissue around and make the wall of the pulmonary autograft more resistant to dilatation. What do you think about that concept, or did you hear any data about that? Or what's your thoughts about it?
Yeah, I think, like you, if it's Dacron, I think it's not a great idea. We recently wrote an editorial. We called it "The Ross in a Dacron Graft is everything wrapped a present?" ? And I don't think this is a present, because you really blunt the expansibility of it. What you're describing, I think, is an interesting concept. And we read these things. They've been talking about it for some years now. But like you, I haven't seen any data about its applicability in humans or any real solid data. But it's an interesting idea for sure. There's also the pairs concept, which has been, I think, applied in some patients for the Ross procedure. Again, I'm not too sure how that works. My biggest concern with these wraps, and even the ones who are resorbable, is that when you look at the data with the pairs, and there's a paper in the Interactive Journal from a group in Belgium, and they looked histologically at the wall of the pulmonary artery after about 6 months in sheep models. And there's complete disarray of the media. The smooth muscle cells are not aligned anymore. And there are pockets, there are cystic pockets within the wall. I think what happens is once you prevent the wall from moving and getting these mechanical signals, the biology of the wall becomes a change. And I'm sure Amin can talk to us about this even better than I do. But I worry that if you remove the mechanical stimulus, that you actually alter the biology of the wall, and that may have a negative impact in the long term on the whole principle of having a living, not just valve, but a living root in the aortic position. So, my impression is that if you control the blood pressure very tightly in the first few months, you can even use that native aortic wrap around it, which is a bit loose on the outside, loose jacket. I think that is, at least in our hands, really prevents the early dilatation of the autograft, which is, in my mind, the biggest predictor of late dilatation of the autograft route. But I'm interested to hear what the other panelists think about these ideas.
I think you have to control blood pressure, at least in Argentina. And we have had patients after 1 year that suspended the treatment, and they have come with mild to moderate aortic insufficiency because they were 160, 100 blood pressure. So for us, the most important is to control blood pressure. The rest we do. I learned also with Jakub, and we do reinforcement and whatever you do. The ROS is something that really works, and as Francisco said, when you change something, you have to be sure, because to see results, you have to wait 20 to 25 years. It's a great operation.
Dr. Francisco, a question for you.
Yeah.
Okay. How do you manage the small aortic annulus in your patients subjected to the Ross procedure? Or you don't operate them?
Of course, I operate them. I think this is more than an indication to do the Ross. We have some patients, by the way, today somebody called me about that, a patient who had operated coarctation of the aorta when she was young, and now has a bicuspid aortic valve and annulus around 17 millimeters. So what we do, of course, we try to match the size of the autograft of the own patient to the aortic annulus. So if this mismatch is just 1 or 2 millimeters, that's fine. As soon as the annulus starts getting smaller, if it's just 3 millimeters, we can do a small manugium and fit the autograft inside. If the annulus is even smaller, then you do a Roscono operation. And the Roscono is not that, if you open just a little bit of the septum, you can really gain a lot and make that Roscono. So of course, I think the Ross is probably, besides the homograph, I mean, it's the only solution for those patients with very small aortic annulus. So that's what we do.
Perfect.
May I make some comment to see what you think? You know, they talk about the Osaki operation. What you are putting there is dead tissue, fixed with glutaraldehyde. First of all, the one who did that first operation was Randas Batista and was cited by Carlos Duran with his work in rheumatic fever in Saudi Arabia. And then he used to do caps extension, mostly rheumatics, of caps with autologous pericardium fixing glutaraldehyde. And now there is a revival of that operation, but what we are using in this operation is tissue that is alive. But Osaki operation, the tissue is not alive because it's like fixing an autograft in glutaraldehyde, will not last. So, because there was a question here about if you consider Osaki. Osaki, I think operation, I don't know what is the indication and what's the big deal about this operation really, because also I know a doctor who also did something similar with bovine pericardium, Dr. Song from South Korea. He also proposed that the arrest time for that operation is almost like Ross. So what are your thoughts to all of you about the Osaki operation? Have you done it? What are your indications compared to a normal biological valve?
Francisco
Me,
or Juan Carlos? No, go ahead.
Oh, it's a question for all of you, mainly for Amin. He hasn't speak. What do you do with complications in the post-operative period, such as endocarditis?
It's not common to have endocarditis after the ROS. I mean, it's the very low incidence of endocarditis. And as a matter of fact, in our experience, I think 7 or 8% of our cases were operated with active bacterial endocarditis, and some of them with some root abscess as well. And we don't have relapses of endocarditis. So I think, and there was a surgeon, I can't recall his name, I think he was from Texas in the US. He published a series of 60 or 70 ROS in endocarditis with very good results. So I don't think endocarditis is a problem. Of course, if you have endocarditis and then you have a destroyed valve, you have to do the same as with other types of operations, but it's not common.
Maybe if I could just say something, I had one case of early endocarditis only on the autograft. The pulmonary homograph looked perfect, and I was forced to do a root replacement, put a new homograft in. So the patient ended up with 2 homografts. And I've also done or did plenty of patients with active endocarditis, and just like Francisco says, it doesn't seem to be much of a problem. They don't get endocarditis; they do very well.
Yeah, I agree. I agree with all these comments. Endocarditis is a rare event on the left side. You will have some endocarditis on the pulmonary homograft, but it's very rare. But still enough that I tell my patients to take antibiotic prophylaxis before they do any dental work for life, because you just want to prevent that right side. Interestingly, the couple of endocarditis we had on the right side, the left side was completely spared from infection. So I think it really reinforces the notion that this is a living valve that can defend itself against bacteria, even when it affects the heart valves. The Ozaki question is a very interesting one, Roberto, because the Ozaki procedure was really designed for older patients. The Ozaki series, the mean age is 67, which I think makes sense. Instead of putting a stented valve, you put a stentless valve. It's all pericardial, whether it's human or bovine pericardium, it's the same. In young patients, I agree with you. To extrapolate these data in old and say that all of a sudden we have a magical solution and we're reinventing what we know doesn't work is a bit strange. I think the only role in anybody that's under the age of 65 or so, or 60, would be in kids who are still growing. Because I think even if you get 5 years from an Ozaki in a 10-year-old, and you get them from age 10 to 15 or 16, where they become a bit bigger, and then you do the Ross, that may actually be a benefit. The pulmonary side is bigger, you can put a bigger homograft and so on, versus if you do it in a 10-year-old, where you may actually have to come back for the pulmonary homograft. But it has to be a clear understanding with the patient that this is not a substitute to the Ross, but just you're buying time before you do it. Once the patient reaches adult size and age, I really don't see much of a role for the Ozaki in a 20 or 30 or 40-year-old patient. I think these patients will come back. It's a non-living substitute. We know what pericardium does. I think doing a Ross in the first instance makes more sense, but that's just my impression. We need more data. There's a lot of excitement, a lot of people just doing it, but I'm not too sure what the data will show. And as Francisco said, we need to collect data prospectively and audit it retrospectively so we know if it does or does not work.
The thing is, if you look at the long-term follow-up of Al-Hales, of this young population, mean age 20, it lasts very long, that operation in that population. But I have seen Dr. Song doing this procedure. They have to do the measures, so on and so forth. It's 120 to 150 harvest time for this procedure. And if you put a biological valve, which is the same, maybe you have to do annular enlargement, Minojan or Nick. That's 10 minutes or 15 minutes more. That should be 70, no more than 80. So I don't really understand. I would like if somebody can convince me so that I will do it, that there is an advantage in all people of Ozaki operation over aortic enlargement or putting any biological valve. I would like to hear.
I would agree with you, Roberto. I think the Ozaki is for older people. It might have the advantage of better hemodynamics in small roots in old ladies, but it's a time-consuming operation. Maybe to make the valve to be exactly a tri-leaflet valve with no insufficiency. I mean, it can be somewhat tricky. It's not that easy. And in older patients, you may have calcified aortic wall. So maybe, as you said, if you make enlargement of the root and put instead of a 19, you can put a 21 or 23 millimeter valve. That's already okay. And nowadays we have biological valves which have very good hemodynamics, 21 to up. 19 is already something which we don't like, but the hemodynamics for those old patients, maybe the patient prosthesis mismatch is not that important in terms of survival. I think Ozaki also claims that there is less thromboembolic phenomena and less valve-related events, but I'm not really convinced about that.
just today, we did a patient who is 17 years of age who had an Ozaki done a year and a half ago, and he's coming back with severe aortic regurgitation. Francisco Anna was scrubbed on that case. She will tell you about it. She did it, but and we had to replace the valve. But the patient, because it happened so early, says, "Oh, now I'd rather not have a Ross. Please just put a prosthetic valve in place." So we had to put a tissue aortic valve, and he's going to be back in less than 5 years or 10 years again to then have his Ross procedure. So, it's one has to be cautious with these with pericardial patches for valve reconstruction in young patients.
What was the mode of failure of that valve? Was calcification, or the valve was in not well positioned, let's say, with asymmetric valve?
Well, the early result was perfect, and at 1 year he developed a severe AI. There was no real calcium on the leaflets, but there was probably a bit of retraction of the leaflets and a severe jet of central AI.
Yeah, it has been an amazing webinar. All the talk was really amazing, nothing to do, really great experience. I don't know if Dr. Stocking or Dr. Bamondes, if there is any question pending in the panel discussion. Otherwise, I think we can finish. Again, thank you to everyone. It's a really, really good webinar. I hope we can join again in the future to find another important topic. Thank you, Amin. Thank you, Dr. Turner. Thank you, Dr. Elmahansi, Dr. Da Costa, Dr. Favoloro, Alex, Juan Carlos. Thank you for everyone. I don't know if there is something pending in the question.
I have one.
Okay with the questions.
Doctor Contreras, estamos pasando la encuesta.
Okay.
I didn't hear a lot. Amin, I have a question for him.
Sure.
Do you hear me?
Yeah, I can hear you.
Thank you. When do you reject a patient? Which anatomical consideration do you have to reject a patient for the Ross operation?
So I think it's not so much an anatomic consideration that a patient characteristic, which is patients with connective tissue disorder or a history of familial aortopathy. Whatever genetic disease process they have going on is likely to affect the pulmonary autograft as well. Interestingly, we were talking earlier about the Ross encased in a Dacron graft, which the panel is not very enthusiastic about. That might be one of the applications of that technique for people who are really willing to push the agenda. Maybe you could envision using that approach in a patient with connective tissue disorder if you had a really young patient who wanted to avoid anticoagulation. But in terms of anatomic considerations, in a young, healthy patient that doesn't have any absolute contraindications, I think you can tailor the operation to suit, a wide range of anatomic substrates.
Thank you.
Tell me one thing. Can we have a copy of the video of this?
Sure. I'm going to receive the recording, I think, in the next day, and I will try to upload to the channel to the Chilean Society. And obviously, I can send you a copy for this video.
Yeah, it's going to be great to have some of our residents and young surgeons who could not attend today to see that meeting.
And in the other hand, all the Chilean surgeons, we have a really big homework. We need to work in our tissue bank. That means it's something we need to do between several centers and try to create a national tissue bank to get the homographs.
That's very good. Congratulations.
Juan, thank you so much for putting this together, and congratulations on everything, all the work you're doing. And it was a real pleasure to be a part of this panel, and these discussions were really excellent. Thank you for moderating it.
Real pleasure.
Yeah, I really enjoyed it. Francisco, your talk, I was thinking, if I'm a young surgeon in training right now, I want to become an aortic surgeon and start a Ross program in my country, in wherever it may be in South America. I think what you have done in Brazil is really remarkable. And your talk, I think, was really, and I'm not saying this just to say this, but you really captured all the elements that are so important, not just in general, but really locally, to start a Ross program like this. I think, I mean, for all the young people, they're so lucky to hear what you just described tonight.
Thank you very much, and you have the duty to prepare one that back to Brazil, you know. The responsibility.
big responsibility.
Okay, right.
Excellent. Thank you very much.
Okay, guys. Thank you very much.
Have a good night, everyone. I hope to see you all in person very soon.
Okay. Bye-bye.
Bye. Good night.
Ciao.